So
Sure.
we're going to be talking about healing from torture and how we can help facilitate that. And I think one thing that's important is during wartime, there is war trauma, correct? And that does not legally meet the definition of torture, but we need to acknowledge that war trauma has a very strong impact on people. And the one thing out from this slide I want to point out is this has grown from the last time I checked, that approximately 90% of casualties in war are with civilians. So one combatant for every 9 civilians suffers a casualty. So we have to just be aware how civilian communities are impacted by direct assaults, perhaps ethnic cleansing, extrajudicial killings, targeting of their resources. It just, it's a horrible thing. Um, and then it's important to recognize what the legal definition of torture is. And you're probably familiar with it, but the important thing is that who inflicts the torture. It needs to be by someone who is in a public official capacity, like government, or someone acting in that official capacity, like a um, paramilitary group or a counterinsurgency. Um, so we need to be aware of that as well. Um, okay, so did this just, yeah, okay. So, and then we need to be familiar with torture isn't just physical. Often physical is what we imagine with torture. Over the years, um, governments recognize that there's physical evidence with torture. So it's become more sophisticated, and psychological torture is often the predominant form of torture, and that's the enhanced interrogation techniques that have been talked about, and then sexual torture, rape and sexual humiliation has been always a part of torture, but it wasn't until actually the 1990s that it was included under the definition of torture because rape was seen as a private crime rather than a public crime. But now it is officially part of what torture can be. And then there's all kinds of deprivation that can occur with torture, social isolation, sensory isolation or sensory overload, sleep deprivation, denial of hygiene, just basic needs of water, soap, toilet, um, no access to health care after injuries or treatment of chronic illness, and then nutrition. Malnutrition is very common part of torture. And why do we see that torture has been so prevalent over the years? And the aim of torture is to dehumanize the victim, to take away their sense of agency and power. So often someone from a community who may be a leader, or a movement who may be a leader, or you don't even have to be. It could be anyone who's at the wrong place at the wrong time who becomes a torture victim because they create an example. When they go home to their family and their community, they're different. Torture alters someone's sense of self, sense of power, and torturing one person can have a strong impact on a family and a community. As clinicians, we need to remember that if you're seeing someone who's a torture victim, it happened. It can't be undone. Over the years, I know that many survivors come in and they're like, okay, you can fix this, right? You can make this go away. You can make me feel differently. We can't do that. Okay. Torture is a life-changing experience, and recovery is a process. It's not linear. It's two steps forward, one step back. We have to be flexible. And treatment, we need to look at the whole person. There are physiological, biological changes that happen with severe trauma, such as torture. There's psychological changes, there's social changes, and spiritual changes in the components of change in trauma. There's no magic pill. I know that over the years, there's been a lot of pressure to do evidence-based, and that's a good thing. But we have to remember people are all different, and methods, which are excellent, sometimes aren't workable within the context that you may be working or with the person. And we'll talk more about that. One of the dilemmas of working with torture survivors is that torture has treated the person as an object. The attempt is to dehumanize. So whether it's a legal, medical, or psychological assessment, we have to recognize that we're getting information from a person, and we have to be careful not to objectify them, because to heal psychologically, the person needs to feel like a person again. And to counter that dehumanization, that objectification that they've experienced during torture. So, one of the things we do is an assessment and talk to people about what the problems are, finding a language that they can understand about what we understand about the changes that take place after torture, and share that information with people. I had actually a friend who was from Argentina who's a torture survivor. And she said when she came to the United States after her release, it was so helpful to her that someone gave what she was experiencing a name. And this was an educated person, advanced degree person, but she felt like she was going crazy, that she was losing her mind. And when she was told that the provider she saw understood that she had post-traumatic stress disorder, that we know about these consequences of torture. So when we think about treatment, we're thinking about a framework. How do we receive people? And what we want to do is help the victim identify what their presenting problems are and how that has affected them, how it's affected their relationships, their sense of self. And then we want to develop a therapeutic alliance with them so that we can work together, we can accompany them on their journey of healing. And that, a lot of our training may have been to be neutral, but I think with human rights violations, it's very difficult to remain neutral, nor is it helpful, because if you remain neutral, as some of our training has been, the survivor can project onto you that all the negative thinking they're having about themselves, that you agree that it was their fault, that they're just a piece of garbage now. So it's important that we also allow ourselves to state that what they've gone through was wrong and that we don't agree with it, that it was a human rights violation. It helps to give their suffering a name and that we understand it. And you're probably all familiar with the symptoms if you're doing the work. So re-experiencing the intrusive thoughts and memories, the dreams, the flashbacks. And of course, if people are having those symptoms, it makes sense that they're going to avoid talking about it, remembering details, being around people who remind them, being in places that might remind them of what happened. So they're avoidance. So sometimes it's a challenge to get people to talk about their experiences. And then the physiological changes that take place during severe trauma, especially persistent trauma, is our central nervous systems are on high uptake, and it's hard to relax. So there's a lot of anxiety and sensitivity, startle reactions, a lot of sensitivities to external stimuli that can bring things up. And then, of course, depression, and an altered self-concept. Who are we? Who is the person after having endured torture? Dissociation. A lot of people dissociate during torture. It can be a coping strategy, but then also it can follow them out of the torture experience, and they'll have these just dissociative episodes where time passes and they're neither here nor there. They're not having a flashback. They're just disconnected from the here and now. And then some may develop psychotic like symptoms. And, of course, somatic complaints are very common. It's a lot easier to talk about headaches and backaches than it is about some of the psychological trauma. So if we think about trauma like torture, it has robbed the person of their power, sense of power and control. And healing is about restoring that sense of power and control. So the first task we have to do is establish safety and trust within our relationship. And healing cannot take place unless the person feels safe with us and trusts us. And the different domains of safety have to do with the body, emotions, cognitions, and the environment, both physical environment and emotional environment, the relationships they have with other people. So those are the different domains of monitoring people and how they're doing. And then, of course, just a reminder for us, working with torture survivors can be very demanding on us psychically as well. And it's important to remember these qualities, which are that we respect ourselves and we respect others. And if we have an interpreter, we're being respectful of them as well. And that we monitor our own awareness of how we're responding to the survivor and what they're telling us. Flexibility, even with evidence-based treatments, we have to be flexible. We have to be honest, confident, clear thinking, hopefully maintain our sense of humor, have genuine caring and warmth and call. Essentially, we want to relate to someone human to human. So the different treatment modalities, individual psychotherapy can be very helpful. It's an alliance between the survivor and the therapist, and we're coming together to accompany them on their journey of recovery from trauma, the severe trauma of torture. And we have to make sure that they're truthful and we're truthful, and that there can be as much disclosure as possible. I know in my experience, sometimes survivors need different approaches in order to disclose sensitive material. And for me, it was always very common that sexual violence often was one of the last things that is disclosed because of the shame around that event. We also have to remember that in individual treatment, it's collaborative, right? We have to maintain boundaries that are safe for us and safe for the client and safe for anyone else who might be participating in the process. And that when you're looking at the traumatic experiences, you're going to be looking at how the survivor is perceiving that, how it's impacted them and the relationships they have. So we can use the therapeutic relationship, this is really the foundation of individual psychotherapy, to restore connection. Torture can break down the person's sense of being a human being, or even wanting to be connected to other humans, because this is a human perpetrated act of violence. And so there may be some resistance or avoidance to make a connection again. It has to be built. And we have to really make a moral commitment that we will tell the truth, we will be honest and be respectful and not judgmental. So we're developing intellectual and relational connections with the survivors. Again, effective listening. I work predominantly with interpreters because I've worked with people from all over the world and in other countries, and I don't speak another language. So, what I've learned by listening, the body tells us a lot. We need to notice the tone of voice, observe body language, notice silences, and then paying attention to the person, avoiding distractions, and really giving the person we're sitting with our full attention. That's really setting that foundation of developing trust and safety. Now, one of the methods I really have come to use is what I call trauma informed cognitive behavioral therapy, but it's really individual psychotherapy using trauma informed cognitive behavioral strategies. Okay. Psychoeducation, providing information, helping people understand what changes have taken place in their body and emotion, relationships, teaching people about the consequences of torture. Relaxation training is incredibly important. If you're doing that effective listening, you may notice that the person is holding their breath often. It's very common for people to hold their breaths when they're tense. So, deep focusing and helping people with deep breathing and other relaxation modalities that they may be helpful. Sometimes, maybe even stopping the narrative and having them move around or tactile, squeezing balls. Think, how can someone learn to let go of the tension that's built up in their body? And by doing that, we're also helping them learn ways to modulate their responses, their emotional responses, their affect, because that needs to happen. We want people to be able not to react, but to respond. And then there's cognitive processing. Um, the event has happened, and then there's this automatic reaction that happens between thoughts, feelings, and behaviors. And what we have to do is help people identify what are the thoughts and feelings and behaviors connected to what are they telling themselves about the torture, about what they are now, and help them find alternatives and make a way of thinking about themselves differently, feeling about what's happened in their life differently, and having different behaviors. So it's really developing mastery over traumatic behavior through this process. Um, I want to mention briefly testimony therapy because sometimes for combatants or communities that have had a lot of trauma, it's a brief therapy where their story is recorded, documented, reviewed, and then a, a printed version of it is provided to the survivor, and it becomes their personal record of the events that happen, which can be part of the family history. It's their personal history, but the family history. And often this is used when there's an archive being created about the, the violations that occurred during a war. Um, Now, the one thing that is very helpful is narrative exposure therapy. There's a lot of like evidence showing that, and this is where to help a person develop a personal chronological narrative of their life events. So you're not just starting with the trauma; you're starting with early life as well, and making a continuum of life. Because with trauma, people often get frozen in that period. They can't, there's a loss of who they were and they can't see a future for themselves. And so building this narrative that allows remembering who they were, what happened to them, and also then beginning to develop a sense of future. And during that time, you are teaching them how to manage that and externalize the experience that they've endured, that they don't have to relive it, but that they can talk about it because they have learned skills on how to manage those responses. And so essentially, the process is deconstructing that maladapted thinking and some beliefs that they have developed about who they are now and what their future can be. So it's really having an ability to manage the traumatic interpretation and responses. And we do that by helping them construct this narrative with empathy and understanding and active listening and unconditional positive regard. Um, it 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 sometimes though with torture survivors, you have to be flexible because things may happen that you may be constructing. You're in this process with them, but then a life event happens. Um, and they can't go back there right away. So it also involves having the ability to be flexible in the treatment that you're doing. I want to mention briefly groups can be very helpful. Survivors groups who have shared experiences can help people realize that they're not the only ones that went through this. So it can help dissolve feelings of isolation, shame, and stigma, and develop a sense of cohesion with other people. Um, of course, there's things we have to look out for. There can be positive potential of mutually rewarding relationships. The group becomes empowered because they're sharing this experience and they've learned to hold their traumas together. As a group leader, you have to watch for any kind of destructive interactions and potential for reenactment of trauma between two individuals or more that are in the group. But the adaptive aspects of a group is that the group members accept each other. And when you feel accepted by others, it boosts your own self-esteem, and then it can help you accept others. So it can be very helpful. I know that during the Bosnian conflict, I saw a lot of Bosnians, and there were all these women who I was seeing, and all of them had rape experiences, but they didn't want anyone to know. They hadn't told their families. And we started a group, but we didn't call it a rape women's group. We called it, it actually, we had them bring needlework and handwork, and they sat in a room, and you put women in a room, their hands are busy, they're chit chatting, they're having coffee, and slowly, as the environment became safe and they developed trust with each other, they began to talk about their experiences. And so it became this very healing group. And actually, when we had to end the group, they continued meeting. I kept hearing about how they were going to each other's houses and continuing to meet. So, in just sort of wrapping this up, I think this is really helpful in terms of how do we know people are getting better? There's been developed from a victims of violence clinic in Cambridge, Massachusetts, 7 criteria for the resolution of trauma. Is the person you're working with, can they manage the physiological symptoms? Are the feelings associated with the trauma tolerable? So physiological is body, right? Feelings is the emotion. Do they have authority over their memories and the ability for them not to be intrusive anymore? That if something comes up, they can say, I don't want to think about that. It's not intrusive anymore. So there you have the cognitive realm. And can the trauma narrative have a coherent narrative with appropriate feelings rather than overreaction, or not overreactions, but reactive feelings? Can they be responsive feelings? Has self-esteem improved? Can have Do they have important relationships in their life? And can they make a coherent system of meaning for the events that have happened in their life? That it doesn't define who they are anymore, but that they have had this horrible event happen, but they can have a future. And then just a reminder to all of you, take care of yourself. Make sure you maintain an awareness of your own thoughts and feelings and behaviors in response to the work you're doing. It's important to try and find balance between work and family and leisure, and that you also have connections and supportive relationships. So, thank you. I hope this is helpful.
Yeah, thank you, Mary. Thank you so much for this very comprehensive overview of the works, and it sort of articulates the enormous experience that you have in working with this topic, and the very practical. And I think the last slide illustrates how important it is to do self-care on top of all the interventions. That's very important. Um, Now, as I introduced in the beginning, we will go right on to the second presenter. And may I ask you, Irina, to introduce Tetiana Sirenko and ask her to take the floor, and then we'll switch to Ukrainian for the second presentation.
Дякую,
Yes. Thank you, Mary. Thank you for the presentation. I would like to say that indeed it gave us a very good foundation for the next presentation, because Tetiana Sirenko will be presenting the experience of Ukraine. And I think Tetiana needs no introduction here, because in the community of Ukrainian psychologists, especially those who work with trauma, Tetiana is very well known. She is a clinical psychologist. She is deputy director on psychological care in the Forest Glade Center for Mental Health and Rehabilitation under the Ministry of Health. And besides being a clinician, she is also a trainer in the Prosecutors Training Center of Ukraine, and she is also one of the experts. Over to you. Yes, good evening. Thank you, Irina, for this introduction. I would just add a few words to the introduction. It just happened historically that since 2015, I have been working systematically with those who survived torture and captivity. And it started with my personal story. Like, I had a friend who was in captivity. He was a prisoner of war. And then when he was released, I understood that, well, there's no system of care for them. So I had to go into the topic. And since those years, I've accumulated some experience. So let me share it. Let me start my slides. So I will be talking rather about the Ukrainian context, and I will just explain how we work. Because in Ukraine, let me remind you, just in case, I'm sure you all know, but the war essentially has been going on for, well, 11 years. And when the war started, the topic of torture became prominent, because if we look at the definition which Mary gave in the beginning, well, the torture is not always war-related, but today we have quite a lot of people who survived imprisonment and captivity and torture. And I don't have it on the slides, but I looked into the statistics that we have, and since 2014, only in official releases, over 7,000 people returned to Ukraine. Quite a lot of them were the POWs, but also there were civilian detainees and civilian captives. And these figures involve people who were in captivity as prisoners. But with the new phase of the war, we saw that there were also many people who endured torture in the conditions of occupation. There were these torture chambers. So in this context, as a psychologist who also works in the human rights sphere, I can say that actually it's many more people than these thousands, because even we here, we all have seen, for example, how people who were tortured in Bucha, they gave testimonies, or in other cities and towns like in Izum, in Kherson, and this touches each and every one of us. Now, in the 21st century, dozens of thousands of people are tortured for just being Ukrainians. And of course, it affects anyone who encounters this. And I understand that this will this will affect all of us, and we have to acknowledge this. We must allocate resources, and we must acknowledge that we will be affected too. Also, what's special in the Ukrainian context is that very often we have the composite effect of torture and long-term isolation. Let me explain. Today, we see more and more people who have been released, who spent 2 years in captivity. So people spend not a week, not 2 weeks, not a few months, but they spend years in captivity. And in my experience, I've seen cases when people spent like 3 years and 9 months, or 5 years, or the last case was that well, a person spent 10 years in captivity. So of course, then the effect is going to be different, because the changes in the personality are going to be quite different. And besides the effect of the torture, we also have to deal with some very serious, specific reactions in the behavior as a consequence of that captivity. And very often they become a challenge for the professionals, especially if we do not understand, if we're not aware that these are these specific consequences.
And my fourth point, every so often after the prisoners of war are released, both civilians and the military personnel, they have to go through all the adaptation phases and the losses, because they also become IDPs. A huge number of civilians become prisoners in occupied areas, such as Mariupol, Severodonetsk, and other places. So these people are freed. They find themselves in government-controlled area, and they have nothing. They don't have a home to return to. They don't have friends or family there. And they do receive some benefits, but those are quite small from the government. So the people are facing immense social challenges. And the reason I'm saying this in the context of psychological support, this is what we call the psychological support early on after people have been released. After people were released from captivity, their function of psychic is impaired. They're immensely disorientated. They need to address a huge number of significant social problems, and they are simply unable to cope with all those problems without the support. And at that point, the clinicians often provide some crisis support services. And it's challenges, because we are specially trained therapists, but if no one does this work, these individuals would never reach trauma therapists. You know, sometimes 300 people are released and we're excited that they are, but it's a lot of work. Somebody have to do that. It takes a lot of effort to help them restore their capacity. What are the challenges during the assessment of the patients that have experienced captivity and tortures? First, establishing trust. Trust is a problematic issue. What torture does to people is impairing their capacity to trust and believe in people. This human-to-human contact is jeopardized, and there's high avoidance levels. The engagement and the motivation of the patient can drop significantly. So you need to be very understanding in this matter. Even if the person hasn't been tortured for long, but torture impacts each and every system of the organism. For example, there are some findings on electrocution, and the findings are that 80% of the prisoners are electrocuted. This is a form of torture for them, and obviously this impacts the endocrine system, the cardiac system, the brain, the limbic system. Absolutely everything is affected. And you as psychotherapist would often face that. What we're also seeing is that people who have been in captivity for a long time are at times they're strong, they can endure, and they can control their traumatic reaction. And therein lie many risks. You need to avoid re-traumatization. And if the clinician overlooks that, re-traumatization might cause severe avoidance. So we need to pay attention. We need to see and hear, because even the body language or the smell of perspiration might tell us that something is odd here, even though the person might say they're all right. You see, as prisoners of war, they had to master these traumatic reactions so that to survive, you know, so that the person isn't killed. But this doesn't help in this new situation, because the psyche and the body are significantly affected by trauma. Diagnosing the symptoms might be a problem. There are many dissociative reactions. People withdraw from the body because the body carries the traumatic memory, the memory of torture. So any medical manipulation, assessment, or contact with the doctor, or a simple injection might trigger a very serious traumatic response. You need to stand ready to face that. And sometimes we might be even able to prevent that. For example, in our hospital, for a simple check of electrical cardiogram, we talk to patient, we explain exactly what is happening, that it's safe, that experienced professional will do that. And we warn the person that it might react, especially if the patient reacts, if the patient had been early electrocuted. Also, PTSD issues might have some odd symptoms might come and go. During a medical assessment, these symptoms might come up, and PTSD is not the most frequent diagnosis. Usually, these people have complex depressive disorder, but the most frequent case are comorbidities, because it's not just the psychological traumas, but also physical exhaustion. As a reminder, people are starved as prisoners of war these days, and they have a lot of eating disorders. However, I wouldn't look at them as issues with eating and as eating disorders. It's just they're struggling with adaptation after what they've experienced. What are comorbidities to PTSD? Panic disorder, also maladaptive coping strategies such as alcohol or substance abuse, dissociation, reaction, avoidance, amnesia, somatization, chronic pain in bodies of unknown origin, and almost every individual has this paranoid reaction or suspicion, and brief psychotic episodes. It depends on when exactly we admit the patient, how much time has passed since he or she was released. There are quite a few paradoxes in the behaviors of these individuals. Torture has severely affected them. So people survived intentional harm at the hands of other individuals, and this intentional component is labeled as the greatest evil in the world because one person inflicts pain upon another intentionally. And we have to explain to our clients, it's quite counterintuitive that these scars cannot be healed alone because of one thing was inflicted by one person to another. It needs to be done in a relationship. Another major challenge are the feelings of shame and guilt. Almost everyone has them. People are ashamed of what has been done to them. If this has been inflicted on me, that makes me a bad person. And they might feel worthless. They might believe that I let down my family, my country, my brothers in arms, and we need to give them positive messages. Actually, that human life is the greatest value, and the most important task of a prisoner of war is to preserve life, and then there are legal regulations in place. Some dangerous aspects of therapeutic relationship. There's the fear of betrayal. If you enter into a relationship, the therapist might betray them. They're afraid of being abandoned, and then they might stop the therapy themselves. They have fear of control. It's a big paradox of control. Torture survivors and captivity survivors found themselves in a situation where their capacity to control was destroyed. And every so often, they hate being controlled. They see it as a huge pressure. But on the other hand, they tend to be the ones who are controlling everything. They would try to control the therapist, and that might give rise to many issues. And the therapist might feel as if they're being interrogated. Of course, they're afraid that the clinician would take advantage to exploit or to intimidate the client, and there's a fear of change. During torture, a person created certain survival strategies, and they're very effective, and people are fixated on those strategies, and it's really hard to dissuade the person from using them. These people struggle to realize that these strategies were effective when they were prisoners of war, but are no longer effective after their release. We use the basic model of healing aid. I have some timeline there, but actually it's quite flexible. The timeline isn't rigid because there are various circumstances of how people are released. They have different support levels, and their medical condition differs as well. People who are freed from torture chambers today, they are not in a safe place, because in Ukraine, there is no place that is absolutely safe. So the environment is trigger in and of itself. So up to 2 weeks is the time frame where they can obtain the psychological first aid, psychoeducation, and then up to 6 months, we shape the skills of crisis intervention for psychological recovery. So we help patients to manage their symptoms. We analyze the symptoms that they find them the most annoying. EMDR is an asset here because we don't really go deep into the story, but it helps to reduce the pain levels significantly. And nightmares. And EMDR is helpful to address that. We also use the narrative therapy that Mary mentioned, narrative exposure therapy. People who are released are testifying, and our team is working a lot with the military prosecution office to train those who do the assessment. We train them on trauma-informed interventions to prevent re-traumatization early on after the person is released and is being interviewed later. 6 months into the therapy, we can access more targeting treatment. And I second Mary that it's a process. It might take a while, because if the impact had been long-term and adverse, to restore the coherence, to restore the wholeness of the person, it does take a while. I'd like to reiterate that an integral part of rehabilitation is the exercising the right to access justice and to restore justice nationally and internationally. This is paramount, and research findings show that until the perpetrators are named, at least named, and it's preferably that they're brought to justice, there is no absolute healing. It's important. That's why it's important that people testify so that punishment follows. I have extensive experience in this field. I studied torture, especially inflicted by the Russians, and I am certain that the Russians are doing because they have never faced a due punishment for it. So psychologists today is completely a non-neutral role today. That might sparkle a debate, and I'm willing to participate in that debate. But I think that psychologists have a major role to play to bring the perpetrators to justice. I'm not talking about breach of confidentiality. I'm not talking about encouraging people to giving testimony, but every so often the psychologists can be helpful. And our psychologists also participate in the effort of the prosecution office, and every so often we work together with the investigators. But we do that if the client requests that, not the prosecutor. And also there have been cases where our team members testified in court, and it was a major support for the patient. This is a real challenge for a clinician because maintaining boundaries is ever more challenging in this context. That's why I call upon you to have supervisions, interventions, seek aid and assistance within the professional community. These stories are complicated, are wrought with pain, so even they might be too hard even for one clinician. So if you have the support of your peers, that might be a very resourceful thing to do.
And I will add a few words about the main tasks of the post-isolation follow-up. So after the client is released, we need to help them shift the focus onto solutions to restore physical and mental health, restore the feeling of safety and control over their emotions and thoughts, and to restore trust in people, essentially, to help them with relationship. And the main objective of rehabilitation is, well, the stabilization of situation and covering the basic needs, restoring the relationship, self-identity, and the restoration of human dignity, because torture is trying to destroy dignity. But I believe that it's impossible to destroy dignity. You can just disrupt the feeling of it. But our task of the task of therapists is just to help people to get in touch with this power, and to make sure that they do not live in torture, in PTSD, but to help them improve the quality of life. And I can talk endlessly on this. Apologies, I think I overstepped the time, but yeah. Thanks, thank you, Tetiana. Indeed, it's always a challenge for the experts who we invite. We keep hearing these complaints that there's not enough time to present everything, because we've been working in this area for dozens of years, but we cannot fit everything into these 25 minutes. But yeah, sorry, this is the reality now. Well, we have to perceive everything in small portions. So now I invite everyone to take part in the discussion. And
But
also, I'd like to note.
maybe we can start with Mary, Irina, if Mary wants to give some reflections on what she heard from Tetiana.
Yeah, sure. It's always interesting to hear about a specific context, right? You're talking about the realities you're dealing with in Ukraine. And I think, doing an overview of treatment options is more general. But I really had a lot of resonance with the things you were saying. And the deprivation that occurs during captivity is profound, when people are held as prisoners of war, or even if they're civilians and they're in that situation. So there's so many things to deal with, and also people are different, so you can't make generalizations all the time about how someone is going to respond to that situation, because people are different. And so that requires us to be flexible. But I appreciate your contextual presentation. It was very good. Thank you, Tatiana.
Yeah, thank you, Tatiana. Just one question or reflection, if I may, and I don't want to steal it, Irina. You may conduct the discussion, but often when we do these webinars, we talk about comparisons to Western situations after the war has ended, and we talk about post-traumatic stress. Now, the war has not ended, so there's an ongoing war. So the everything that we talk about is taking place in the present day and state. So the same thing with torture. And what I learned from you, Tetiana, also the passion with which you bring this to the floor, and what I perceive no, and that's great aspiration, and the fine line, if I may, between justice and I'm not a legal expert, and mental health care. And so that's my heart resonates with you when I hear you say justice and the names need to be known. So you're fighting a sort of similar battle as the patient, as the one who has been tortured is fighting to reconnect with their own self and the connection with lost selves in their families. just a reflection, and then I would like to give it, Irina, to steer more time to the interaction with the people at the floor, because it would be really important to hear from you your reflections most, if we can. But Tetiana, just a few words, if you wish to respond to this ongoing situation versus the one that typically, when we invite a presenter from the West talking about peace, reflecting on the situation that has been left.
Ну, ми дуже довго в цій боротьбі, насправді.
We've been in this struggle for quite a long time. And I think that Ukrainian experience can actually be a treasure trove for the world, because there are a lot of experience here, a lot of painful experience, but also lots of resource to overcome it. And like, I have hope that we will overcome the enemies, not only through fighting with arms, but we'll be able also to counteract the consequence of the trauma. So the survivors will be able to restore the resource, and they also become a powerful driver in the society overall, because they bring the testimonies, they carry the testimonies of these inhuman sufferings which were inflicted. They can testify, they can say that, well, it's there and it shouldn't, and they create the progress. We are now building the new system of supporting people who survived torture. We are essentially rebuilding the law enforcement system. It becomes more trauma-informed and trauma-oriented. And this experience probably can be a good example for other countries. I hope that no other country has this experience, but if necessary, we can help. Thank you. So I think it's now a good moment to move to the questions from the audience. There is a first question in the chat, and also feel free to raise your hand and just unmute and voice your question, because we want to see your faces and hear your voices. The first question is from Natalia Koshel. Natalia, are you here? Can you unmute and ask your question verbally? Good evening or good night. Yeah, I have a question to Tetiana. We've met in your facility in the forest Glade, but back then, for some reason, I didn't ask the question. So, on the basis of your experience, you have many groups with the military, these former POWs, and just people who had combat experience. Can we merge them? Can we work in the same group of POWs and people who just experienced combat? Well, we have different experiences, and it evolved. We used to work with them separately. We worked separately with people who survived being POWs, and we were preparing them. But well, now it's different. Like today, we started a training session called The Tribe. It's the post-traumatic growth training for the veterans. And well, 1/5 of the participants are people who survived the prison, and being POWs. So it depends. It depends whether the condition is stable, whether people can endure the level of frustration in the group, whether they can tolerate it. So I think it's a matter of selection of participants, but yeah, not dividing by topics of trauma. Thank you. And we look forward to getting more questions. I also see some important comments in the chat, because the topic of justice, justice, human rights violations, they go hand in hand. And indeed, it is a great honor for us that our colleague Yael Daniele is with us. She's one of the founders of the concept of reparative justice, and she was also developing the notion of psychosocial support in international criminal courts and tribunals. And Yael is commenting that, yes, justice is for the victim, for the community, for the society, for the nation, and for the international community. So it's important at all the levels. Yael, if you would like to ask or comment, we would also be happy to hear and see. So, Yael, hi.
I can. Do you hear me?
Так.
Oh, okay. Tuck,
Yes.
I know Tuck. Yeah. Yes, Irina said it as well as I would have. I just want to add that for those of you who are very interested in reparative justice, at the on the website of our center, we have the whole series of webinars that are dedicated to the different issues raised in reparative justice. But for this particular conversation, and Tetiana, I was very moved. Well, I was very moved by both by Mary and Tetiana, but you recognized very importantly that justice itself is a healing, a necessary healing element after one was exposed to the crimes we are talking about. And what reparative justice adds is that it's not the justice not only in the outcome, that is to decide on the guilt or innocence of the perpetrators, but the whole process of justice with all of the elements in the relationship that both of you spoke about in the therapeutic relationship. The same elements have to be held in the relationship of the victims with the criminal justice system. So let me stop here. But thank you for your wonderfully moving presentations.
Thank you for being with us, Yael, from New York.
Of course.
Так, вибачте, в мене теж якісь технічні проблеми, але я хочу задати
Yeah,
питання.
apologies. I also had some technical issues, but I want to ask a question to Mary, because you had experience working in both a specialized facility when you treated the consequences of torture, and you were providing care there, and you worked in communities. You worked at the level of villages or towns. You worked through interpreters. So could you just explain a little bit what's the difference between different contexts, and what should we avoid when you work in a community setting, or perhaps some details on that?
Yeah. Thank you for the question. Yes, I think in communities, it's important to have a partner of some sort, and who are the community leaders, and work with them as well. You know, you're coming in as, you come in as an outsider, or your team is outside, and you know, one of the first tasks is to develop connections. So who are your partners? Who are the people in the community that have respect? Are they elders? Are they young, you know, sort of passionate people who are taking a leadership role? Is it a combination? But I think that is really important, to identify those people and to work with them. And that gives you some credibility as well, that you are working with community members. And then taking, you know, every community is different as well. So it is learning from, we're students as well throughout our whole careers. As far as I'm concerned, we're always learning. And I know that for us in a lot of Western countries, especially the United States, we're receiving survivors from all over the world. It's not that they're from one conflict. And so there's always this need to adjust to culture, to language, to customs, to worldviews, which can be very different. And that requires modifying your approach. And so that's true when you go into post-conflict settings is, I've got a foundation of knowledge, which I believe is transferable, but what modifications and adjustments do we need to make and to take the lead from community? Did that answer your question? I know it's different for the Ukrainian context. If you're working with Ukrainian communities and you're Ukraine, you're not having to make perhaps all that kind of adjustment. But I do think identifying who are your partners in a community who will give you some credibility as you develop trust with them.
Мгм. Дякую, Мері. Да,
Thank you.
дійсно, в Україні досить
Thank you, Mariam. Indeed, in Ukraine, we are quite homogeneous, but there are, for example, people who survived torture and they moved abroad. They are now elsewhere in the world, and they also need care. They need social support and psychological care, and they also face the judicial system. And then we Ukrainian specialists, we also have a challenge when we have to explain to the international specialists what are the cultural features of Ukrainians. And sometimes it's difficult to do when you are in Ukraine, when you get used to your community, and only when you have experience working with the survivors from, I don't know, Eritrea or Uganda or South Sudan, when you understand how behaviors might be different, then you get the ability to better understand also the Ukrainian features. Because, for example, the colleagues tell me that Ukrainians are quite shy sometimes and restricted and reserved about our needs. Sometimes we are shy to talk. And the story that Tetiana shared, that a psychotherapist sometimes is a case manager. A psychotherapist helps sort out all the social issues. It might be a challenge in Ukraine, but also if the person is abroad, they don't know the language of the country, they have the experience of POWs, and they just need some medical care. Yeah. So, colleagues, if you have any questions, and I know that you definitely work with such clients, feel free to ask or comment. We still have a few minutes to hear you.
Марто.
Martha, over to you. Good evening. I'm so excited to see this distinguished assembly. So inspiring when so many people are united, aiming to achieving the same goal. Restoring justice, of course, is essential for a victim, but when it comes to discussing the justice system, not just in Ukraine, but for example in Poland, where Ukrainian NGOs are also collecting testimonies, then it's very hard to talk to the law enforcement in another country. Well, you see, for them, the crimes that were committed on the territory of Poland vis-a-vis their citizens obviously would have a higher priority, and that's understandable. I use Poland simply as an example, but this is the present situation, and the progress is slow. Communication, perhaps, is the greatest challenge. because the systems lack coordination, and the collection of testimonies is haphazard, erratic, and it's hard to understand how long it's going to take for Ukraine, because you collect testimonies and then you relegate these materials to the Ukrainian prosecution office, and the Ukrainian prosecution is only shaping this process. It's a very beginning. Obviously, it's more humane now with the inclusion of psychosocial component. So naturally, there are ample challenges. So I encourage you to contact the government bodies and not just Ukrainian government. The law enforcement, given the sheer amount of victims, needs to change. Also, the weakest link, in my experience, is the monitoring and evaluation of psychological services delivery. There are numerous services and many costs are allocated for it. Much money is allocated there. But I feel that this is a system that is being reborn after 2022, practically from scratch. There was a fresh start in 2014, and now there's another fresh start in 2022. Therefore, communication is key in this field, and yet it's far from perfect. A case in point is the WHO efforts and suggestions. Let's maybe develop a common language so that we're on the same page. So you need to assess the needs. You need to identify how exactly we're going to help in this process, and communication between different stakeholders, including the governments of the countries hosting our victim population. I second Irina's point totally, that the victims are ample in other countries as well. They have specific medical needs sometimes, and our healthcare system isn't always capable of providing even the basic treatment services to the survivors of sexual violence related to war, to the persons who survived certain types of tortures that impair health for many years and sometimes cause irreversible harm. This is it from me. Thank you for giving me the floor. Thank you, Martha. I see that we are receiving many words of thanks to Mary and to Tetiana. And we have one question in English. And after that, I think would wrap up for today. We'd give the floor to Tetiana and Mary if they would like to conclude the meeting with their remarks. But the final question is for you, Tetiana. How long would the treatment in the forest Glade last on average after the captivity, and what happens next? For example, an individual has been treated. Is there any follow-up? So what's the patient's pathway? Irina, it's a simple yet a very difficult question. So if these are prisoners of war, it takes 1 month or 1.5 months for us to treat them. Then they might be referred. If it's a civilian, we refer them to the host community where the person is traveling. Then we have partners, organizations, and we try to organize follow-up. If we're talking about military personnel, and we have many, they need to be back in active service. And then this process is adjusted depending on the condition of the patient. if a person has not recovered and must go back to an environment that's triggering, you would see the increase in their symptoms, and they could be referred to military hospitals later on or to our facilities, the Forest Glade. Then an additional military medical commission is called, and we count on the new law that will soon enter into force, because this would allow the military personnel to recover as long as they need. But the present reality is just as I described. Thank you, Tetiana. Right then. With that, I think we could sum up. Mary, maybe you have additional comments or a summary statement, a final message for us, if you have one. We'd be grateful.
Okay. I think you can tell from both presentations that torture treatment is complex. There's so many different domains that a person needs to heal. And often programs don't have the resources for all those domains. And so it's very important to have collaborations and partnerships to try and develop a network who cares for a survivor and their needs and the needs of their families. Because there's the primary survivor, and we really didn't talk a lot about this. There's the primary survivor, but then there's the family that they may return to and the impact that has on the family. And then there's the community, and how does the community respond to that family and individual? Are they supportive or are they not supportive? It's a complex issue, and there never are enough resources. And sadly, we're living in times of conflicts all over the world, serious conflicts. And sometimes I worry, not sometimes, it's like one of my worries is the next generations, because we're also, the intergenerational impact of survivorship from torture and war. It gets passed down generations within families in different ways. And I'm worried about future generations as well. So I think we're as a global community, as Ukraine, as a country, and the global community, we're going to have a lot of reorganization of our priorities to deal with, I think, of resources. And, I want to say less aid through giving arms that support these conflicts, but then that's a whole, that you have to look at that. That's a complex issue as well. But, what are the resources that are going to be available for rebuilding lives and countries after these, hopefully, wars are resolved? Tatiana?
Yes?
Чи могли б, можливо, ви як
Tetiana,
побажання,
Tetiana, maybe you have a final message to wrap up the webinar. And after that, I think that would be the end. I'd like to express my gratitude to the organizers. Thank you, Mary. Thank you, Eric, for joining us. Thank you for sharing your experience. It is very much appreciated, because sometimes we are in this echo chamber and you need to broaden your understanding sometimes. So I appreciate a great deal that there's a lot of interest in this topic. I remember the times when the situation was quite different. That gives me hope that our community is expanding. Of course, we can team up and act together. And, this effort would ripple. If every person does their share and helps at least 5 people, that's something. If we have 50 people, then we would create quite a major network. So please do not lose your contacts and networks. Please team up. Please do not be estranged. Thank you for providing this opportunity for me to share my experience.